Okay, perfect. So, hey, everybody, I am Frances Walsh, and welcome to the Disabilities and Universal Inclusion Network Response Team, our first meeting of the year. So the purpose of the Disabilities and Universal Inclusion, NRT, is that we work to inform the network and the broader oral health community on opportunities to support health equity for people with disabilities. So some focuses include universal design and access, educating oral health providers and professionals about the needs of people with disabilities in accessing oral health care, partnering and engaging in national disability incentives, and supporting equity-aligned policy and advocacy. So I figured if we wanted to do a check-in question or wait until it's like time to introduce ourselves, but the broad sweeping agenda for today is really to just ground us in that purpose statement, which is what we've now done, and then to hear from you all who you are, where you're from, the work that you have going on, and then we'll start to brainstorm together what is it that we want to do this year. And so no more than 3 goals is what we're asking because things can get pretty lofty real quick. But so what are some priority areas that we think by the end of 23, this is what we'll have done? So any activities that we can think of and some outcomes and plenty of chance to connect, learn, and share from one another. And I will pause there before I hand it off to Barbie if there's any clarification or anything at the outset of this meeting. Okay, hearing none, I'll hand it over to you, Barbie.
Great. Well, thank you. So should we just start with introductions? Probably that's probably a good place to start, right? Don't you think?
I do.
Okay, so I'll go first. So I see new faces and a couple old faces from our previous NRT group. So I'm Barbie Vartanian. I am currently the Director of Advocacy and Policy Initiatives at NYU Dental School, and my primary focus is on disability. It's a newly created position that I've been in for a little over a year and a half, and my sole focus is to advocate for the disability community, from everything, from policy initiatives to, integrating new programming within our Oral Health Center for Persons with Disabilities. NYU has probably the largest and most comprehensive and interprofessional specialty care clinic in the country. We work with bringing in federally qualified health centers and training their dental staff. We've integrated a lot of really great programming. And then prior to that, I was the president, the president's on the phone, the executive director of Project Accessible Oral Health, which is a global initiative to improve the health outcomes of individuals with disabilities. And that was founded about 4.5 years ago. I am now the vice president. Steve Perlman, who you'll hear from in a second, is our current president. And just working with a lot of national, disability organizations, primarily the American Academy of Developmental Medicine and Dentistry, for which Steve Perlman founded, and again, just understanding and the importance of collaboration in all of this. And as Ellen, who is kind of spearheading the group last time, and Vanessa and I kind of put our heads together this time, and we all join these coalitions and these groups, and we really, everyone has the best of intentions, and everybody's working on such incredible things around, trying to support this community. But we really wanted to hone in on one thing this time, and we're all really excited about that. And we're hoping you guys can too, because obviously we have representation from a national level. And that focus for us is we'd really, really like to drive the Heads Up Act. And what that is if you don't know what it is, it's declaring individuals with intellectual and developmental disabilities as a medically underserved population. And within that comes a whole host of different things that would benefit this community, but really trying to hone in on maybe a few specific areas within the bill. And we have the experts of the experts. So Dr. Perlman was instrumental in drafting the legislation, and he's been driving this for very, very many years. And then Vanessa understands it from a state perspective, and Pennsylvania is doing incredible things. They're very close to getting a governor's exemption in the state, and they would be the first to declare individuals with IDD as a medically underserved population in the state of Pennsylvania, which is huge. So it's great to see it being tackled at the state level, but obviously we want to continue at the federal level and attack legislators from every angle. So I'm going to leave it there, and then I'll turn it over to Vanessa next. Thank you guys for being here. Appreciate it.
Thanks, Barbie. Hi, everybody. I'm really excited to have Dr. Perlman on the call because I know he and Barbie have been working on this for so long, and he's like a legend in this area. So it's really great to have him on this call. Yeah, we are really trying to do something to move the Heads Up Act. We have been working on it at a state level. Thankfully, we have a new governor in Pennsylvania who was a very health equity focused attorney general. And so we've been working with his chief of staff and deputy secretary for policy and planning. So that moves forward very slowly, but it still moves forward. And then I also sent around just quickly to some of the folks in this group. There is like Barbie said, we're working on really moving the Heads Up Act this year. And so some of you, all of you, will have access to several spreadsheets that have the names of the legislators that we really want to target. Yeah, and I'm sorry, just supposed to be doing an introduction. So
that's okay. We're all rambling.
So I'll stop. But I would like to hear from Dr. Perlman if he would like to jump in next.
Oh, thanks. Thank you for inviting me. Barbie called me this morning and said, "What are you doing at 3?" And I said, "Well,"
I forgot to tell him earlier. I'm sorry.
And I never say no to her. So thank you for having me. So I'm the old dog. I mean, you hit it on the head. So 50 years in the field of special patient care, almost, and been through it all. It's interesting. So, we have a curriculum committee now. So we're drafting the curriculum for undergraduate dental school, thanks to a grant from Delta Dental, undergraduate curriculum in special patient care. And they asked me to write the history. That's how old the dog I am. So it goes back to the Academy of Dentistry for the Handicapped. And I guess that, so I'm private practice completely. In my roles, I had to have an academic route. So I come from a private practice background, and mainly a practice that dealt with the crap that everybody deals with. I mean, I saw my practice, my partner was a pediatric dentist and an orthodontist. And the nature of what we did, I saw my practice go from 22% Medicaid to almost in the 70s. So when I hear people say that they can't do Medicaid or they can't treat Medicaid or whatever it is, it just makes my blood boil, because it can be done if you're good at it and get successful. Anyway, so I'm a clinical professor of pediatric dentistry still at Boston University and the University of Pennsylvania. And I guess so many, many years in special care dentistry, but the two turning points were in 30 years ago almost. Eunice County Shriver asked me to create a health program for Special Olympic athletes. So I created the Special Olympic Healthy Athlete Program, which now is the largest public health program in the world, with 8 health. I'm big into interdisciplinary care. So interdisciplinary care. And then I guess my biggest claim to fame is co-founding the American Academy of Developmental Medicine and Dentistry, which is 22 years old, because I saw that I needed to ride the cart of physicians. If we're going to get anywhere in healthcare and move it along, dentistry by itself is not going to get anybody's attention, but we have an intercollaborative organization. And we've been able to come up with policy statements to improve the quality of life for people with ID that dentistry alone could never do. COVID policies, hospital visitation policies, ventilator, I mean, you name it, medical immobilization policies and things like that. So we're having our annual meeting in 2 weeks, which is going to be fabulous. Everybody's welcome. But so the MUP issue, it's interesting because now I can send you the documentation. Do you want to talk about that a little? Is that
yeah, I would definitely. I think everyone would love to hear the history of it, and then we'll definitely shoot out and I think
I don't want to take up anybody's time or introduction, but basically it goes back to 2004. In 2004, the AADMD picked up the MUP issue. and it thought it was an easy fix, but it's been the worst ride imaginable. And I've had one-on-one with the President's Committee for People with Disability, with Senator Harkin, Senator Kennedy, multiple. Everybody says, "Oh yeah, I'll fix it," but nobody even attempts to do anything about it. So it's been a really rough ride, and it still is now, because Moulton introduced the bill, but it's never been scored. He doesn't seem to care about it. He's actually my congressman, and somebody said, "Why don't you just go down and talk to him?" But I have talked to him about it, and it doesn't seem to do anything. But anyway, if we think there's maybe one magic bullet that can fix some of this or help, it's medically underserved, because it would be loan repayment, which is number one what we want. We want loan, because everybody's talking about high loans, graduating school, poor workforce, all the that I can go into barriers to care with a whole lecture about it, but loan repayment would be a big incentive, because following loan repayment, actually, it was pointed out that the minute you get MUP status, it's loan repayment. So we don't have to fight for that. But the other key thing are money for research and money for faculty development and things like that. That's all part of MUP. So it's really a critical issue that we move in. And Vanessa, you're doing great things. And am I going to see you? Are we going to see you at MISDA?
Oh, she's on mute.
Sorry. Yeah, I'm always muted. Yeah, I hope so.
Okay, good. Then we could, so, because really it's people like Vanessa that are give me renewed energy because it's tough. It just gave me in 2010, the American Medical Association passed MUP on the first round with no problem. They got it, they passed it. In 2010, I went to the executive director of the ADA. I said, medicine passed it, and they have a safety net, the hospital emergency room. Don't give me the runaround. 2011, 2012, ADA, nothing. In 2012, I got a letter from the ADA, which I framed, that says granting people with intellectual disability, a medically underserved, will do nothing to improve access to care. I have it. 2013, nothing. And in 2014, I said, I'm bringing a busload of Special Olympic athletes, parking it in front of ADA headquarters. But actually, we got it passed, but it was only the states that did it. And the ADA refused to pass designating people with ID a medically underserved population, but they did it finally. So that's the saga. And this is what we're honestly up against.
All right. Thanks, Steve.
Sorry, I didn't mean
No,
to.
no, that's good. No, with a little bit of background, lots of passion. That's why we're here.
It's not an easy lift.
No, it's not. It's not. But if we all put our, our minds and our, passion behind it, we can do it. So Christina, do you want to go next?
Hey everyone, my name is Christina Lusk. I am a communication specialist for AIDPH, the American Institute of Dental Public Health. Physical disabilities is one of our new areas of focus, and I have a disability, so I just wanted to hop on and listen in and see what AIDPH can do.
Yay, great. Thank you for joining us. Beth, you want to go next?
Absolutely.
All right.
I'm excited to be here, and Vanessa and I have met and talked about this at length. I am Beth Pierce. I'm the Oral Health Program Manager for the Maine Primary Care Association. And actually, I met Francis and I met Vanessa, I think, in July at the Open conference. So it was awesome. And that really spurred me to have some conversations with the Primary Care Association about the medically underserved populations in Maine. And I actually I'm worked for our state Medicaid office. And prior to that, after that, I had a brief position with the Office of Aging and Disability Services. So I already got the connection about dental and underserved individuals with needs. Then I went on to manage dental practices, and we had contracts with the Office of Aging and Disability Service in substance abuse and mental health services in Maine to deliver services to special needs population that had lost funding for services that they had received out of a couple consent decrees with 2 different psychiatric facilities in the state of Maine. So what happened is there was some contracts written between our practice and another provider to deliver services to this population. That included a whole gamut of high functioning to nonverbal, non-tactile individuals that needed to have dental care. And one of the things I did when I was at the dental practice was to help the dentist that was leading this effort to get these individuals into services under sedation when necessary in a day surgical center in Southern Maine. Unfortunately, I left and he's left. I have no idea if this population is getting any services. So I'm especially passionate about this because I participated in caring for these individuals. And now I support the federally qualified health centers in Maine, which is an ideal location for these members to receive their dental care. I mean, they're co-located with medical practices. If IV sedation is needed, you know, we can have a nurse anesthetist on staff supervised by a medical provider right there and take care of them. So I had a meeting with Vanessa and several other interested parties really talking about what this would mean. And it really would directly support a lot of the care to be delivered in the FQHCs in Maine. Unfortunately, our leadership at the PCA said, you know, we can't invest in that. But I did have a really good meeting facilitated by a colleague with the Disability Rights Maine organization here. And they're very interested in this and they were pursuing it. So I continue to talk with them and want to bring back to them, you know, what this is. They may be the entity that brings forward legislative action, but then they would partner with us as the PCA to develop those services in our federally qualified health centers, which I think would be ideal. And obviously the FQHCs would benefit from all the things that would come out of the IDD population as being identified as medically underserved, which we know is, especially in dentistry. So that's my little soapbox speech.
Yeah, that's great. And it's obviously that's one of the things that's embedded within the bill is the federally qualified health center funding. And that's what I was kind of mentioning, you know, so NYU and Penn, I think are the only two currently through a Delta Dental grant. They're funding federally qualified health centers from various states to come to either one of our academic institutions for like a 3-day immersion program. And they come in and they get hands-on, and it's dentist, hygienist, dental assistants, front office, their CEOs, their CFOs, just so they get this, you know, this broad understanding of how to treat the population. And then they're also learning like the front and the back end too. So it's proving to be really successful. So there's a lot of, you know, interesting programming that's happening.
That is wonderful. I've been very interested in bringing education and serving the special needs population to our dentists at the FQHCs. And when the practices I managed negotiated these contracts with our DHHS divisions, there was individuals that came in and provided some of that education as far as understanding the population and their needs. But what they didn't provide and they had to learn was some of the things that you're providing when it comes to the clinical education and working with these individuals, which I think is fabulous. And I would so love to see come to our practices here in Maine.
Yeah, we'll have to, I don't know which Delta has your oversight. So all the Deltas are getting on board with it, and they're bringing, like I just had a conversation with, I know I'm going off track, with Delta Dental in Virginia, and now they're going to start sending some teams. So, so yeah, there's opportunity to
Northeast Delta Dental. I already work with them for some loan repayment, but they're very active in the state with veterans, AIDPH. And I would love to see them do something in this one.
Definitely. Nicole, do you want to go next?
Good afternoon, everybody. I apologize about the informality. I am traveling today, but my name is Nicole Payon. I am the Policy and Advocacy Coordinator for the Pennsylvania Coalition for Oral Health. Very excited to be a part of this roundtable discussion, and I can anything I can do to echo all of the amazing work that Vanessa is doing in our state. She really is wonderful at leading this issue, and PCOH is very happy to support and assist her on this effort. So thank you.
Thanks, Nicole. It's great to have you. You guys are doing great stuff there. So
I have to jump in just really quick to say that Nicole did such a fantastic job. They PCOH did a great social media campaign for 321 Day. It was fantastic, and they really Nicole particularly, and Helen. We did a sign-on letter to the governor, and they got an incredible number of health organizations to sign on. It was really fantastic. So Nicole does great work. I'm happy to have her here.
Yay. Rafa, you want to go next? Doing the squares.
Yeah, hello. My name is
Hi.
Rafa Castañon. Coming to you from Michigan. I work at HealthNet of West Michigan, project manager whose focused is oral health. I actually, wanted to join this discussion. I actually saw Barbie and Dr. Perlman. I think you guys presented
Oh
at
yeah, we
the
did.
Michigan Oral Health Coalition.
Yes.
Yeah. So this is kind of
Yeah.
a further in what, kind of what you guys had talked about at that session. It's kind of furthering, for HealthNet and for Kent County as a whole, health equity is a very important value for us. So anything that can help us bring, health equity towards the populations that we serve is always going to be a benefit.
Awesome. Welcome. Yeah, I was having some major AV issues at that.
Oh, that's right.
I don't think any of and none of my videos worked. It was a cluster. Anyway.
It worked out. It worked out.
Yeah, I was fine. You guys are amazing. So is it Shineri? I don't want to pronounce it wrong. I can't.
Hi, Chinyere.
Oh, okay. Sorry about that.
All right. I am Rafa's supervisor. So as he's joining and getting acclimated with you all, I also wanted to join just to get a feel for what it is that you guys do so that we can have better context when we talk.
Great. Thanks for joining us.
Yes, of course.
Is that Bonnie Stanley? I'm not, I just see P and I'm thinking maybe there she is. I know Bonnie. Hi, Bonnie. You're on mute.
That's how my day has been. I'm so happy I only have one more.
It has been one of them.
Sorry, are we introducing ourselves?
Yes, you are introducing.
Okay. Good afternoon. I'm guessing it is for me. I got one more hour to go. I'm Dr. Stanley. I'm the dental director for New Jersey Family Care. And I'm really working to push the needle in New Jersey to allow us to not only identify providers that are seeing individuals that have intellectual developmental disabilities as well as other special needs, but the next step is looking at ways to engage providers so that they will be open to training that would allow them to feel more comfortable with treating the population. We do have quite a few providers in New Jersey that are seeing our patients, but the distance is often a problem. The transportation is often a problem. And to try to support that, we are looking at implementing telehealth benefits for that population so that they can connect more easily to a dental professional and to see how we can slowly and incrementally improve access, because the providers that we do have are like in my age cohort and they're looking at the light at the end of the tunnel, which would be right before you get to the beach. So, that's the other challenge. It's just, I graduated from University of Maryland, and at the time we had a special needs clinic. And I'm going to tell you that was like 30 plus years ago. And to see that it has not been embraced and implemented as a part of everyone's dental education is interesting, because it gives you skill sets that helps you to treat all patients. So I'm here for the work. I'm happy to see I got partners in this.
Yay, thanks, Bonnie. I can speak personally. I get to work with Bonnie a lot in New Jersey we had a task force specific to special needs. Unfortunately, we didn't get the additional funding to keep it going, but it was a great group of people, and she's been leading the charge with all the MCOs in the state. So thanks for joining us. Gary, I think you're last. Welcome, last but not least.
Well, I really didn't think I was going to get on here, so I'm glad to be here. I'm Gary Harbison. I'm the executive director of the Missouri Coalition for Oral Health. And I guess we're just saying how we kind of interface with this area.
Yeah, that'd be great.
I have a longstanding interest in service for people with disabilities in a former life. Well, I used to do a lot of things in former lives, but I was the chief of the Bureau of Special Healthcare Needs in Missouri, so have a history there and an interest. Right now, the coalition has a project funded through the Missouri Disabilities Planning Council. And basically what we're doing is using teledentistry to increase access to care for people with intellectual and developmental disabilities. It's a 3-year project. We intended to do 3 separate kind of demonstration projects. We started in the St. Louis region, and now we're in the Kansas City region, just on the Missouri side in both instances. We're probably not going to open a 3rd region because we're finding out certain things, and one of those things is very much, I think, there's a lot of reasons it happens, but it's very much a systemic observation, and that is the entire sort of service system, and I think indeed the families and individuals themselves just really do not have dental care, seeking dental care and getting dental care as something that's integrated with anything that they do. And that has, we've been taught that lesson several ways now. So now we're talking about, well, what are some systemic changes we could make so that that is no longer the circumstance? And I'll stop there. I could go on about it for a long time.
Great, thank you. Yeah, so just to go back a little bit. So when the 3 of us met, Alan and Vanessa and I, again, we thought, okay, let's try and hone on 1 or 2 things that we can focus on to where we can say we actually potentially got something accomplished. Whereas before, I mean, again, everybody had the greatest intentions, but it was, more of us just kind of giving an update as to things we were working on, but we kind of weren't collectively coming together to work on something together. And that's really what we want to try and accomplish. So that's why we thought, okay, all of us trying to drive the Heads Up Act in either at the state level or through, federal engagement, and then using the resources of open, so I just got the email today that they're getting ready to do their virtual Hill Day. So I think there's ways in which they can support us in our efforts in doing this. And so I'm going to leave it there, and then I'm going to punt it to you, Vanessa, to maybe, get the consensus or talk about any other ideas or whatever else we might think of.
Yeah, no problem. So CareQuest has been incredibly helpful in all of this work. We did have a meeting with Melissa Burrows. So Families USA, which is a great organization, has flagged the Heads Up Act as one of the top legislative opportunities for 2023. So they are getting more involved in that. Like I said, we met with Stacy Auger from CareQuest Foundation and Melissa Burrows, and they both seemed to think that because we've had lots of these conversations before, and I've spoken with Dr. Perlman, and Barbie has also been at this for a long time, and there seems to be some I don't know how to say it, non-movement or slow movement from Representative Moulton's office. Representative Fitzpatrick really would like to move this. However, and maybe that's more of an opportunity now that the Republicans are the majority in the House now, but Melissa Burrows and Stacy Auger both suggested that we might get farther with the companion bill in the Senate. And so that's kind of been something that we've been working toward. So we have reached out to Michael Gamble McCormick in Senator Casey's office, because this is kind of his turf. And also Kelly Jackson, who is a staffer on the Help Committee, but she works in Senator Patty Murray's office, who is also the chair of Appropriations. So we have a meeting coming up to talk with her about supporting some kind of Senate action on that side. So that's kind of something that's moving. We're just going to take the bill as it is and send it to Casey's office and see what they say. We'd like to shore up a little bit. One of the great things, and I know that Gary pointed this out, the Heads Up Act, if you haven't read it, it mandates comprehensive and integrated dental care, which checks off a couple of boxes that, you know, we've been working on through CareQuest for a long time. So that's kind of where that is at. We are pitching that to Casey's office, and we are trying to, you all will have access to the spreadsheet. I put together a spreadsheet of our folks who are like our, I don't know another word to say it, like prime targets.
Yeah, no, that's perfect.
Yeah, but folks that we really want to get to. And so we are focusing on the Help Committee, and we have Casey's on that committee. Senator Sanders is chairing that committee. Senator Murray is the immediate past chair and is still on that committee. And I'm working with Gail Brown from the New Hampshire Coalition to try to get something set up. I think we're gonna work with Able New Hampshire to try to get to Senator Hassan, who is also on that committee. So everybody will have access to that spreadsheet. We would, as Barbie mentioned, this is a team effort that absolutely cannot be done alone. And so we are really hoping that folks will have a look at that spreadsheet, be willing to reach out to whoever your legislator is, whether that be your rep or your senator, to pitch the Heads Up Act. So, I mean, that's all that I have kind of at this point, but that's kind of, that's where we are in terms of kind of pitching this to the Senate.
Okay, I think Beth, you have your hand up.
I just had a question. When we're talking about the Heads Up Act, which I've read since talking to Vanessa, and they're talking about the comprehensive and integrated dental care, how does the changes in Medicare and what they're covering now and the diagnoses that they're covering, and they throughout that whole text, they constantly phrase something to the effect of, you know, it's integral to the care that people have these services. I'm just wondering how that supports these initiatives. And fortunately, I heard when I was in DC at the end of March that Senator King here in Maine was present for, I guess it was the virtual Veterans Day on the Hill, and was quite interested in that. So that makes me feel really hopeful that he's someone that could be engaged in this.
I talked to Senator King's staffer just a couple of weeks ago. And so we would really like to talk to his office again about it. I'm not sure. Are you talking about the CMS? I'm aware of the Medicaid, the additional codes that have been approved through Medicaid. I'm not sure if that's the one that you're talking about.
No, it's Medicare. Medicare has a plan.
Medicare. Yeah, Medicare,
yeah.
That's the one. I know that Wei Wei Kwok, who has been kind of heading that up, the one concern with that is that it's extremely narrow, and it is not, and integral is not clearly defined. So it's an extremely narrow group of conditions that are considered medically necessary. We're kind of trying to work to expand that as we go. But those are the two issues or challenges that we see with it right now is that it's extremely narrow and it is not well defined. And I know that if we talked at after MISDA, I believe, Dr. Perlman and Barbie and some other folks, that maybe if we do a Senate companion bill, maybe we want to avoid those issues and put some clear definitions of what we would like to see as comprehensive and integrated. I know that one of the suggestions from Families USA, this was to pitch the EPS. I never get this acronym.
EPSDT.
That's right, EPSDT, to pitch the EPSDT framework as what we would consider comprehensive. Representative Moulton's office was not amenable to that, but yet Representative Fitzpatrick's office was. So, and then we haven't moved forward anything yet with integrated. So, but a really roundabout way of answering that.
That helps. I mean, I agree. I think the Medicare coverage is terribly, terribly limited. They're not even considering head and neck cancers as a diagnosis that would qualify, which it clearly does. And prior to all this, I worked in oncology as well. But that's not coming until 2024. But I will stop there because I see Dr. Perlman had raised his hand.
Yeah, I was just going to, Steve, real fast before I just wanted to mention that I don't know if all of you have seen, but the National Council on Disability just released their report last week. And this is one of the, the key recommendations that was made to the president. So it's definitely, that's why we feel like the timing is right now to make this charge, because it is top of mind. So go ahead, Steve.
No, I was going to say that I don't know if so. The National Council on Disability finally released their report. It dragged on for months, but they finally released their report. And it's like 100 pages, but all you have to do is read the first 2 pages because it's the recommendations to the president. And Mary Foley and MISDA is probably doing more work on this than anybody else that I know, and really positive work. And a positive note, working with the National Council on Disability has been really, really good. I don't know if you all know this, but 2 years ago, well, we've been fighting forever for people say the 2 biggest barriers are, lack of training in dental schools, which they're addressing, and then lack of reimbursement. So, but it's much more than that. But anyway, the NCD actually went after the dental profession 2 years ago and made them change the code of ethics of the profession. So up until only 2 years ago, the dental profession code of ethics was a dentist could not refuse a patient because of age, gender, sexual orientation, blah, blah, blah. Word disability didn't appear in the code of ethics. So all parent, caregiver, group home, whatever it is, called up dentist office, I don't want to do it. I'm not trained enough, whatever it is. End of discussion. Now, because it's mandated in the code of ethics, the change, so they inserted the NCD, helped us more than anybody else just by inserting the word disability in the code of ethics. Now the dental schools no longer can get away with only treating diagnosis and treatment planning. Now there's competency in the curriculum. So everybody's scrambling now to meet the code of requirements so their dental schools meet the requirements. So the NCD has been a great organization for us to work with. And actually, at the meeting next week, their lead attorney is going to be there talking about next steps, which everybody's talking about. The interesting thing is that the MISDA, Mary Foley, and you guys brought up the fact of Medicare. Like, okay, so Medicaid's the answer, but it's a problem. It's the answer because it's the only federal program that can work with this population, but it's a problem because the states don't have the funding in Medicaid programs. So they're looking at putting something in Medicare, but we actually had a president's meeting this week, and the past president of the ADA said the minute you bring up Medicare and that word to the dental profession, it's done. The conversation is over. So I don't know how we're going to fix that. as a little background, last year, at the AD and the annual meeting, we really made history. We had the president of the American Medical Association and the president of the American Dental Association on the stage for the first time in a fireside chat led by the National Council on Disability. And the theme of it was, okay, you guys, you've dropped the ball all these years. How many more studies do you need that people with disabilities are the most medically underserved population? And I've had, for 45, 50 years, we've been fighting with the public health people. It's not on their radar either. It's African Americans, Hispanics, and Native Americans. When they talk about underserved, that's what they focus on. That's all they want to talk about. People with disabilities are the largest underserved, but they're also the most invisible population that there is. So one of the things that's really important is everybody wants to know the numbers, because this is going to cost. Whatever it is, it's going to cost. So we've done some work over the years. Do you know that under the age of 5, the government only counts blind and deaf? So there's only 155,000 kids listed, and that excludes all the, look at the new CDC report 2 weeks ago, 1 in 36 with autism. They're not counted anywhere. So what's the number? Everybody wants to know, what's it going to cost? What's the number? And we really need to figure that out. If you look in any of the literature today, it's going to be 7.5 million people with intellectual disabilities and 52 million people roughly with big D, big disability. But it's not 7.5 million. And we're collaborating. A new player in this field is May Pham, a physician with the Institute with Exceptional Care in Washington. And she has been doing a deep dive with us, and the numbers are really 10 to 12 million with ID. It's a lot different than 7.5 in lobbying for this population too, but it's still a manageable number. When you reach it, the minute you go to big D, 52 million, there's not a government program that's going to pay for that. So I think we have to really hone in on ID only, right? And then figure out how to, Vanessa's been doing amazing work. Vanessa, you're the brightest star that it's been in the last couple of years. But Vanessa, what do you think about it? Is it true? I mean, the minute we brought that at the president of the minute he said, I'm with you guys. But the minute I say the word Medicaid, Medicare, the conversation is over. How do we fix that?
Honestly, to be totally truth, I don't even say Medicare or Medicaid anymore. I just call it public insurance, because I think that Medicaid and Medicare are just have become such loaded words that as soon as you say it, it's automatically you're totally shut down. So
yeah.
I mean, that's been my experience anyway.
I don't know. I don't know if any of you all also, that just took place a couple weeks ago, there was a Senate hearing on oral health care disparities that Cardin and Daines' office put on. Senator Daines is from Montana, and then Cardin's obviously from Maryland. He has become an oral health champion. I'm not really sure why, but he's introduced a lot of legislation in Maryland. Obviously, just implemented a full comprehensive benefit for adults with within Medicaid. So, but anyway, ironically, I'd had multiple conversations with them, and I was very encouraged that I thought disability would be included in the discussion. And as Steve and I were watching, I mean, it was all about rural health. It was about teledentistry. The one gentleman who was a former president many years ago from the AAPD, the only mention of the disabled community was needing to open up the ORs because that's where this population needs to be treated. So it was very disappointing, unfortunately. And again, that's after a lot of conversations and hopefulness that they were going to touch on it in the right way. And anyway, so there's obviously a lot of
but
work.
not all that population needs to go to OR, and with the comorbid conditions, you don't want to have general sedation unless it's absolutely necessary.
Absolutely.
So there really needs to be that triaging hierarchy of what do they truly need and where are they best served. And just I'll try to make it brief because I know we don't have a lot of time. I am the former EPSDT coordinator for the Office of Main Care Services in Maine, so I'm very familiar with the program. I'm also familiar that it was was put into the Social Security Act because they could not get the soldiers into the military because they didn't have adequate oral health. So they developed this benefit. Lo and behold, they'll give it to the kids and the soldiers to get them in the military, but they're not providing it to the soldiers when they're out of the military. So that's another issue with the veterans. But this has really got me thinking about, you know, having worked for Medicaid, you know, we have been educating our dental providers, billing, coding everybody in the health centers about the Medicare benefit, and they have the advantage of having medical providers enrolled in Medicare, so they have people that can credential them and get familiar with it all. Unfortunately, CMS has not clarified the billing structure on those services in Medicare, but it does make me pause and go, what can we do with FQHCs where they are already connected with HRSA and CMS? And actually, in my time as an EPFET coordinator, I remember dealing with Ms. Mary Foley, and it's great to hear that she's still doing that great work. So just a couple thoughts. Is there, the last thing I'll say is Maine initiated their comprehensive dental care for adults in July of last year. I said from the get-go, we would have problems with access because we don't have enough dentists enrolled. And then coupled with that fact in New Hampshire, you know that, Gary. Do I have that? Yeah, Gary, you are from New Hampshire, right? No, I have the wrong state. I apologize.
Missouri.
Missouri. So I was really focused on how do we educate our practices to be able to serve the populations they haven't worked with before, and special needs is a really, really big one. I'm kind of losing my train of thought, but I did have some success when our Medicaid program increased the fee-for-service rates for the enrolled dentists with the introduction of this new benefit, but it didn't impact the federally qualified health centers because they get paid by encounters and not fee-for-service. But we were able to argue with them that fixed and removable prosthodontics were being done at the FQHCs at a tremendous loss. And being that they're part of the safety net, we really asked them to consider what else they could do when there was a lab case involved in delivering those services. And we've gotten some traction along with our rebasing for the FQHCs and their encounter rates. They are now going to be allowing those series of codes that I provided the department with to be billed as fee for service to the FQHC so they can get the full reimbursement rate. So it just says to me, there's ways to get creative.
Yeah, no, definitely. And that's one of the things that Mary's really looking into is all of those. I just actually was on a call, and you should probably join it. And I can send you offline. I forget what our collaborative's called, but she's looking into the ICD-10 codes as a possible means in which, you know, to be creative. So that's really what Mary's focused on, is all about thinking outside of the box, because inside the box is not working. So trying to come up with, you know, and Mary's the one that, you know, put together the report for the National Council on Disability, and many people on the call helped, you know, in various ways in putting that report together. So, yeah, so it's good stuff. So, well, I'm just going to quickly try and like pull us all together. I think, you know, for next steps, I mean, maybe we get with, you know, we'll get with Francis and Ellen and Vanessa, you know, kind of what some of our thoughts were. So probably about a year ago, we had a wonderful gal who used to work on the Hill. She was Henry Schein's chief government person that they had just hired. Amazing. And so what she was doing, and we probably did about 20 calls with various state legislators. We started with, there was 3 of us on a call. It was Dr. Perlman, it was Mary, it was myself, and we kind of touched on, Steve gave them a little bit of the history. Mary talked a little bit about the reimbursement model. I talked a little bit about what the private sector was doing. I also told a personal story. I have a son who's profoundly autistic, so I can sell that part of it as well. And we had these great conversations. We asked them to take a look at the bill. We weren't trying to say, hey, we want you to sign on immediately. We asked for their feedback. We asked them to join the disability caucus. Like, we were really kind of trying to just engage them in all these different ways. So the thought is to maybe kind of reenact something like that. Like, all of us, you know, we divide and conquer, we make a list, we hit key committee members, you know, we hit the likes of Senator Cardin's office again. We get Kathy McMorris Rogers, who has a son with Down syndrome. We make our top 10 list, and maybe we all come together and and try and set up these calls, and I can get help. We have a, you know, a lobbyist here at NYU. I'm happy to ask him to help us set some of these things up. We can definitely use the open network for that kind of help. So we'll maybe put together a game plan, and we can maybe talk about it the next time we get together, if that sounds good to everybody.
Bobby, Jackie Schaefer, she concentrated only on the Energy and Commerce Commission, right? Because
It was that one in Senate Finance. We were trying to do Senate Finance too, because they oversee.
Okay, because it's the Energy and Commerce that's going to do, Vanessa, right? This goes through Energy and Commerce, nothing. So anybody else can put some, you know.
Yeah, we'll put
some
together
people.
our list of who's on the right committees, because that's the other problem that's happened to the Heads Up Act is we're not getting, you know, Moulton and Fitzpatrick aren't on the ones that we need them to be on. So that's why we've got to go outside the, you know, those groups and get on the ones that really will make some traction.
So just a little history. So Moulton is he's actually my representative. He's like 3 tours in Afghanistan and, great Harvard credentials and stuff like that. But everything he does, his whole career is military based. This is the only thing that he's really sponsoring because he has an uncle with Down syndrome. And even in the local paper, they had a list of they interviewed him and what are his 10 top item agendas. It wasn't even in the newspaper article. So, and I got a great lesson from my friend Jim Brett, who's head of the President's Committee for People with Intellectual Disabilities. He said, if this isn't the guy's #1 target, then forget about it. He's not going to do anything to it because they just do things for favors for people. Mm-hmm. So Vanessa, how do we get around that?
We got to get creative.
Isn't he an advocate for veterans' oral health?
He won't give up this bill. That's the thing. It's never been scored. It's going nowhere. It's too broad. It's too expensive. We tried to talk him into just cut it all, everything out except MUP, but he won't do it.
Go for this. I agree with CareQuest and with Families USA. I think that the Senate, it might get more traction and I think that folks here have access to some senators that are heavy hitters in that aspect, and I'm willing to give it a go because I just really don't. I mean, personally, I sent advocacy materials and I contacted every single rep on the Energy and Commerce and Appropriations Committee, and it just didn't do any good. But like I said, we're talking next week with a staffer, Senator Murray's staffer on the HELP committee. She seems interested. So in terms of just access, it seems like it's been easier on the Senate side. So that's kind of our plan for now. Because I just don't see any way around Moulton.
Yeah. Well, we have a great champion in Casey. I mean, he couldn't be more, involved in this subject. So, and yeah. So I think that's, and from you all, I mean, if you have, folks that you have a direct line to that you think we should be reaching out to, like we can just kind of discuss that next time we all get together. And like I said, and then we'll formulate a game plan. Does that sound good, Francis? And then maybe you can let us know like what Open can help us with in terms of, making some of those connections and helping us establish some of those calls and.
Yeah, absolutely. So, and we have the Hill Day, this virtual Hill Day, that will be September 12th and 13th. I'm not sure that that's been released yet, but that will be soon. Oh, I see that Stephen has to.
No, I have to go. I'm sorry.
Okay.
Nice to meet everybody. I didn't know another call at 3:45. Bye. Thanks.
But so I'll throw the recording link in inside of these notes, and then we have it sounds like we have our orders for the year. So this is exciting. And then if we want to tack it on to that Hill Day or bring any.
Yeah, definitely. That would be awesome.
Yeah, I was going to just say, I think another thing that we could look at is how Medicare crisis services, because they have criteria for how rates are developed that don't exist in Medicaid, which could be something, once we look at it, it could be something that will be more engaging to dentists. Because right now, you just do what you do in the state, but Medicare rates have a basis for what they are, which are higher than Medicaid.
Right. Yeah,
So
definitely.
knowing that a dental provider could see a reason why having benefit in Medicare.
Right.
And I just had to excuse myself because I've been in this game so long. I'm so
Yeah,
sick
no,
and
no,
tired of
go.
people
We're gonna
talking
go.
about it's gonna cost too much. It's gonna cost, what's it gonna, you're paying for it anyway.
Right.
Yeah.
You know, I mean, you're
They're already
paying for
paying
it
for it with their
anyway.
ED claims and, you
Yeah.
know, over
Right.
medicating individuals that really their issue is oral health, and that's where they need to be treated.
Mhm.
Yeah.
And if we have a better workforce that is trained in
Yeah.
providing care to all people, that means that we as a profession are not limiting access to care.
Right. Yeah.
Yeah,
Definitely.
that's a great point. Universal access benefits everybody.
Yeah. But I
Yeah.
mean, if you can treat, I mean, my other, I'm gonna get off the bandstand, is that why do we make people feel guilty because they do not want to have dental treatment with local anesthesia?
Right.
If you want to be sedated and that's what's keeping you from being a compliant patient or accessing care, then as a profession, we need to address that as well. But it's just, you know, like it's one more barrier. I'm just like,
I know. Too
fit
many.
to be tied.
Yeah. Amen to that.
Yeah.
All
But I can
right.
only think they're little tiny steps that are moving us towards improvement. I just don't see it. I'm just gonna keep watching it. The needle is
I know.
moving slowly.
It is moving slowly, too slowly. Yeah.
Mm-hmm.
All right. Thanks, everybody.
Alrighty, these are monthly meetings?
Yeah.
Okay,
Are we monthly, right, Francis? I think. Yeah. Okay.
okay. All right,
Perfect.
thank you.
With the notes and everything, so.
Okay, great. Thank you.
Thank you.
Bye, guys.
Bye.